What I find is patients come back to clinic and sometimes if you're a physio or if they're going to a physio that's seen a lot of my patients, things are going really well. But I'm probably one of the main surgeons doing patellar instability surgery. And so there's a lot of physios and rehab practitioners that don't see a lot of patellar instability. So when you don't see a lot of something, it can be very confusing. And so our goal today is to give you a framework to approach patients, because it really is quite logical, as you'll see. So this is what we're going to go through. We're going to talk about NPFL reconstruction, some of the concomitant procedures. So probably the most common you see will be tibial tubercle osteotomy, otherwise known as a tibial tubercle transfer or a TTT. And then of course, many of you have seen some trochleoplasties come through our clinic, and we'll talk a little bit about that because you won't see much about that in other places. And then Sarah, who's the real expert on rehab, will talk about our approach to physiotherapy and how we rehab these patients. And we'll end with some little talk on bracing. So patients come to you with patellar instability. So this is when your patella dislocates out laterally. And really the question is who do you send to a surgeon? Why do we fix it? Who do we fix? Why do we fix them? When do we fix them? And that's probably the first decision you need to make. And the reason this becomes difficult is because patellofemoral instability, so PFI, patellofemoral instability, it really is difficult to manage. And the reason it is because there are so many things that can predispose a patient to dislocate their patella. So if you go through the literature, you can come up with at least, and there's probably more than 18 things or associated factors. Now, some of them are demographic, so things like sex, age at first dislocation, probably family history, race may even go into there, but things that will predispose people to dislocate the patella. And then the things that surgeons think about more would be anatomical things or biomechanical things. So things like patella alta and trochlear dysplasia, where you don't have a nice groove, you have a shallow groove. Things like a lateralized tibial tubercle that change your vector of force on the patella. So all these patients have different associated factors, and they may have them to a different degree. So if you do the math on that, and this is why you have to go to school and do your math, but even if you say that patients have mild, moderate, or severe of any of those factors, you can see the number of combinations each patient that walks into your office can have is huge. So every single patient that comes in that I see is unique. And it's pretty rare for me to see someone that's exactly like someone I saw last week. Everybody has a little bit different conglomeration of factors. And therefore, every treatment that we design for a patient from a surgical point of view or a rehab point of view is going to be different. And this is why knowing the principles is so important. So what do we fix? So if a patient comes to a surgeon and they want to get their patella fixed, so their patella is dislocating, and usually we fix those that dislocate more than once, so they have recurrent patellofemoral instability. The big player that we all talk about now is the NPFL. So the medial patellofemoral ligament is a ligament, and it's really a thickening of the capsule that goes from the patella to somewhere right around the medial epicondyle. So the NPFL kind of acts like a leash, and when the patella wants to dislocate laterally, it just stops it from moving laterally. And biomechanical studies have shown that the NPFL provides about 50 to 60% of the lateral restraint. So when patients come with a dislocating patella, we need to stabilize it. So you can imagine the patella cannot get over to the lateral aspect of the femur without tearing all those structures medially. So when we stabilize the patella, we want to reconstruct or repair the NPFL. Then when we talk about all the other procedures we do, like a TTO or a trochleoplasty or a derotation osteotomy or a lateral release, those are really looking at the biomechanical or anatomic environment that the patella sits in. So you can imagine if someone has a lateralized tibial tubercle, that lateral vector of force on the patella is larger. And this is why I tell all my 16-year-olds they have to go to math class and learn their vectors. So anything that increases that lateral vector will cause more strain and make it easier for the patella to dislocate. If your groove is shallow or even an anti-groove or convex, you can imagine the patella is so much easier to dislocate. And if you have rotational abnormalities, so femoral anteversion or internal rotation, or tibial external rotation, those forces on the patella are going to make it easier for it to dislocate laterally. So these are all the things that we look at. So when we consider what we're going to do for a patient who has lateral patellar instability, what I always tell people is the NPFL reconstruction, so the ligament reconstruction we do, its purpose is to stabilize the patella. So when you push on the patella laterally, it's a leash or a tether that doesn't let that patella dislocate with a normal amount of force. All those other procedures we do really serve to improve that anatomy and biomechanics that patient may have that's abnormal or outside normal parameters that make those forces on the patella greater. So if you can sort of separate those into a stabilizing procedure and then procedures we do to improve that anatomy and biomechanics, it makes it a little bit easier to conceptualize. Sorry, this is acting on its own. So post-operatively then, the recovery after surgery, what I usually tell patients, it's probably 6 to 12 months back to pivoting sports and normal activity, but that really depends on the muscle strength and how their muscles are activating and the condition of the patient prior to surgery. The true reality of it is it's probably muscle control and strength that limits their return to sport more than healing of the ligament. So this is where NPFL reconstruction is a little bit different than ACL reconstruction. As you know, ACL reconstruction, the patient's raring to go, and we hold them back from pivoting activities because we want the graft to mature and become stronger. NPFL reconstruction is a little bit different. For the most part, the patient is not ready to go, even though the graft is strong enough. So it's an extra articular graft. There's not a lot of tension on it. So that whole rehab environment is different for an NPFL reconstruction than an ACL reconstruction, despite the fact that the rehab protocol is very similar. So our rehab protocol really focuses on strength and function, especially of the core and hip. One thing I would encourage you all, because we talked about NPFL or patients with patellar instability are all very different. If you're unsure about what happened or what pathology is in the joint, get that OR report, call the surgeon, get that OR report and read it. And you'll see exactly what was going on in the surgery. So a lot of times, almost 95% of patellar instability patients will have a chondral lesion of the patella. So if patients are having pain post-operatively, likely it's due to quads inhibition or poor quads function or poor core function, or it could be due to a chondral lesion. It's almost never due to a meniscal pathology, so that's very uncommon in these patients. So don't be afraid to get that OR report so you really understand what happened in the surgery. So let's just talk a little bit about the surgery. I think it's very difficult to treat these patients unless you have some understanding of the surgery. And I know many of you have come to the OR and watched one of these surgeries, and I think it really helps to understand what's going on and what the patient is experiencing as you treat them post-operatively. So this is a drawing of an NPFL reconstruction. And just like an ACL reconstruction, our goal with an NPFL reconstruction is just to recreate that anatomy using tissue from somewhere. And that's usually a gracilis tendon. So it's a smaller tendon that we can take. We can also use semi-T. We can also use a very thin strip of the quadriceps tendon, and we can also use allograft. So we take some tissue and reconstruct the NPFL anatomically. So again, you can see it's a fan-shaped ligament that goes from the patella to close to the medial epicondyle of the femur. And you can imagine if you try to push that patella medially, this will act like a tether. So it really reestablishes that lateral restraint. And what we have seen with quite good mid to long-term follow-up now is these patients do really well. So if you look at stability, if you look at function, and if you look at quality of life, these patients do well if you can keep their patella stable. Do many patients still have pain post-operatively? Yes. And a lot of that is due to chondral lesions. It's due to poor rehabilitation in that they might have difficulty getting their muscles to fire appropriately. And it may be the chicken and the egg. They may dislocate their patella because they're unable to activate their muscles well. So it's hard to know which one it is. But many of these patients may have some issues, but we're actually quite good at stabilizing the patella and returning patients to good function. So let's talk about the TTO. So this is probably the procedure that I get the most phone calls to the office about. Most of that is because rehab protocols for TTO are not well described. If you go do a lit search, you'll get many different variations on the rehab protocol. But again, this is where I like to stick to principles. So there's two different ways we do a TTO. So one is we just move the tibial tuberosity medially. So the goal of the TTO is actually to reduce that Q angle, so to reduce that lateral vector by moving the patellar tendon medially. But since tendon heals really badly to bone by itself, we actually move it with a slice of bone, because bone, the awesome thing that it is, heals like gangbusters. So we move the patellar tendon medially with a slice of bone that we hold in place with 2 screws. And this reduces the Q angle, which reduces the lateral vector of force, which improves the biomechanical environment, so our NPFL reconstruction can work less hard to keep the patella in place. So the other thing we can do is move a tubercle distally. So in patients who have a high riding patella or a patella alta, we can move the patellar tendon distally, which brings the patella into the groove quicker and stabilizes it. So our principles for rehab are really to allow for bony healing. So as most of you know, bone takes about 6 weeks to heal. If we move a patellar, a tibial tubercle just medially, it's actually a very stable osteotomy. And most of the time we actually just crack the bone. We don't actually take it right off and put it back on again. So it's a very stable osteotomy. So what we've been doing at Banff Sport Medicine is locking people straight for 2 weeks and then allowing active range of motion. And then depending a little bit on patient characteristics, how reliable they are, how stiff they are, keep increasing their motion to protect that osteotomy. But really it's healed by about 6 weeks. When we distalize a tubercle, we actually have to take that tubercle right off and bring it down. So that's a much more unstable osteotomy. So those patients we're a lot more careful with. So we tend to slow them down for the full 6 weeks. So when you see those differing rehab protocols, that's the reason why. And then they're all altered based on our patient characteristics, how stiff they're getting, how reliable they are, how slippery it is outside, how icy it is, and how likely they are to slip. These patients all have pain with kneeling afterwards. They can have pain from the screws. Let's face it, you can see those screw heads. There's just some skin over that bone. Those screw heads hurt, and we often take them out. So we really just want to avoid direct pressure over that site, and it's going to hurt on the front of that tibia.
Laurie, just a question from Liza about moving the tubercle distally, whether or not you pair that consistently with a quad tendon release.
Well, you have to release the fat pad to get the patella to come down, and then you have to release laterally just to get the patella down. So remember, our goal is to move the patella distally, not necessarily move the tubercle distally. So you don't release the quads, you release the medial and lateral retinaculum as much as you need to bring the patella down. Does that answer your question, Liza? Sorry, I can't see the chat when I'm screen sharing, Sarah. So, okay, I'll assume that answered that maybe. Oh, sorry.
Yeah, thanks.
Okay, yeah, okay. So, so what we're really doing with that TTO, like I said, changing that vector of force. So the expected outcome, this is like all osteotomies, like high tibial osteotomies. An osteotomy is a very powerful operation because you're moving bone and you're changing biomechanics. So the TTO is an excellent procedure when someone needs it. So the trouble I see with TTOs is when you use it, when that tubercle is not lateralized, patients can have trouble. But for the most part, if you're using it for the correct indications, it's a super powerful operation and it gives good bony stability. But there is a downside, right? You're cutting a tubercle, you can see my saw here. You're cutting a piece of bone, you're moving it, and you're attaching it with screws. So it's not without its morbidity, but it's very successful and a very powerful operation. Trochleoplasty, my favorite operation. So this is relatively new to North America. And as you know, we started doing these in 2014. I went to Europe and trained to do these. And our goal with the trochleoplasty, really it's a big long word, so it looks like we're really smart, but really we're taking patients who have either no groove, so a very flat or even a convex groove, and digging a new groove. So we're basically creating an osteochondral fracture. We're lifting up a flap of bone and cartilage. We're digging out a groove, and then we're laying that cartilage back down. And that sounds really horrendous, but again, this is an osteotomy. We're changing the anatomy to give good bony stability to recreate that groove, and it's a very, very powerful operation. So it's creating that new trochlea for the patella to track in. We always combine it with our stabilizing. Remember, we use an NPFL to stabilize. We use all these other operations to improve the anatomy and biomechanics. So the rehab for a trochleoplasty is actually no different than for an NPFL reconstruction. The patient, there's no reason they can't wait there. There's actually a good reason to move the knee, because as you move the knee, the patella will actually compress the osteotomy and push that bone together. And as we know, bone heals under compression. So actually motion is good, and it's very good for their muscles and getting their muscles to activate. It's good for their swelling. It's certainly good for their psyche that they can do stuff, and they're allowed to wait there. So actually our rehab protocol for trochleoplasty is no different for the NPFL, but you need to understand that these patients had a flap of bone lifted and a piece of bone dug out. So they're gonna bleed more, they're gonna have more swelling. They may have more quads inhibition because of that swelling. I have not found that they're more painful, interestingly, and we could go into my theories about that. But for the most part, the trochleoplasty, you just have to understand that that patient journey might be a little bit different because they had a bigger operation, but the rehabilitation is no different. So our principles are get that knee moving, get those muscles firing, and we only inhibit that when we need to allow for bony healing. There's a few other things we do which are much less common, and you may have seen some of them. So derotation osteotomies is where patients' legs are turned. Again, we can derotate a femur, we can derotate a tibia. The rehab then for our NPFL is limited again by our bony healing. So usually bones take 6 weeks or so to heal. We'll hold the patients back depending on the osteotomy for a time for that bone to heal before we allow them to progress on to their rehab. Lateral release or a lateral retinacular lengthening, you'll see on a lot of operative reports. And with that, it's basically like balancing the tires of your car. So if a patient's patella is very tilted, we're going to tighten up the medial side or tighten up the medial side. We're going to stabilize on the medial side, but we need to release on the lateral because we want that patella to sit in the groove, pointing to the ceiling, not pointing over to the window. So lateral release is really just a soft tissue balancing. It shouldn't need any changes in your rehab protocol. They just might be a little more sore or have some swelling laterally, but it wouldn't change your rehab protocol. Some of these patients will have ACL tears. The mechanism to dislocate your patella is very similar to the mechanism to tear your ACL. So you will get some other ligament reconstructions. And again, whatever is the slowest to rehab ligament is the one we use for our rehab protocol. And then like we mentioned, many of these patients do have cartilage lesions. The cartilage restoration procedures are really quite rare in Canada. They're much more common in the United States and in Europe. But there will be patients that have cartilage lesions or some cartilage restoration procedures that we need to consider as we're rehabbing. This is why we really encourage you. We're happy to supply OR reports, but really listen to the surgeon's protocol. Ask questions if you're not sure. And with that, I think I will hand it over to Sarah to talk about the important stuff.
Thanks, Laurie. So I'm going to chat obviously about the rehab considerations that we have with respect to NPFL reconstruction in particular, and happy to answer any questions afterwards. So graft strength with the NPFL, as Laurie mentioned earlier, unlike the ACL, it's extra articular and the graft itself is stronger. So once you have that bony healing 6 to 8 weeks, after the surgical intervention, even though you continue to have some bony remodeling, that graft is actually quite strong. One of the things that we do encourage is to get that swelling under control early, because swelling, as we all know, particularly in joints, can be really problematic for stiffness. And so if we get that swelling under control in that first few weeks after surgery, then you don't tend to have stiffness of the patellofemoral joint. If you do notice that there is stiffness in the joint after surgery, it is important to mobilize the joint, but it's also really important to avoid, obviously, stretching that graft. With these patients, we use a phased-based rehab protocol, and we really avoid rushing progressions. And as Laurie's already mentioned, we have a big focus on hips, quads, and core strength. And this is not the most exciting thing for patients. And so it's really important that we encourage them and make it sound like it's the most important goals of their treatment to actually gain that hip and core strength, like actually being able to do those planks and do the 4-point activities if they're able to kneel, obviously not for a TTO patient, but is really important to enhancing their rehab outcomes. And we actually know this from research that we've conducted looking at gait for patients with patellofemoral instability. And so we've done 2 studies, one that just looked at gait compared to patients that didn't have patella instability. And that showed that these patients do tend to avoid going into full extension. And if you think about the patella, that's where the patella, if your knee is extended, the patella is kind of floating. So the reason these patients avoid going into that full extension or using what we call an extension avoidance gait is to avoid their patella being in that most unstable position. The other thing that we found from our gait studies was that these patients have a very, very weak hips. And in actual fact, a lot of them who've been doing rehab, trying to actually rehab their knee following a patella dislocation, will actually have reasonable quadriceps, but actually have extremely weak hips. And so it's one of the things we found in our gait studies. The other thing that we determined was that these patients do actually improve their gait and improve their hip activation if they're wearing a patella stabilizing brace. And that's likely because we actually get a little bit more extension and much more normal motion otherwise. And so it is really important to consider those aspects. And then with respect to what Laurie was saying earlier about the other structures, just being mindful if you are treating someone who has had a patella dislocation acutely, that we're not just talking about the NPFL being disrupted, but there is actually injury to some of the other aspects of the capsule, and there may also be chondral injury, which we'll chat about a little bit further. Next slide, please. So the next thing we're going to chat about is prehab. And so prehabilitation has become one of the mainstays of orthopedic surgery, particularly for the knee. And there's been quite a bit of research on this that shows that prehab exercises do lead to improved recovery. One of the things we've found with our patella instability patients is that patients then are able to learn the exercise, but most importantly, they learn the use of the neuromuscular electric stimulation or the electric muscle stimulator. And this is really integral for these patients because so many of them, if you think about the underlying anatomy that Laurie's already been talking about, if we think about it from the rehabilitation perspective, these patients also have abnormal development of their musculature. So if they don't have a normal groove, for example, or they have, really not a good fit between their patella and their trochlea in their femur, they often also have corresponding hypoplastic or underdeveloped quadriceps musculature. And this is actually quite a common finding among patients with trochlear dysplasia or other aspects of patella instability in terms of bony abnormality. And so it can be frustrating for them when they're attempting to do their rehab. And so the more well-versed they are before surgery in doing these exercises, and in particular using the muscle stimulator, the better, because it really does help force that muscle adaptation, which in many of these patients is diminished. As I said earlier, addressing that core, hip, and quad strength. And for this reason, we really make it a 2-part prehab program that we recommend. One is activating the quadriceps and ensuring that we get really good quad strength. But the second part of it, the second 6-week phase, is really activating the hip strength. And then also focusing a little bit on increased functional capacity. So as we've seen with a lot of these patients having the extension avoidance gait, they actually need some gait retraining even before surgery. And then the other really important aspect for physio, if you're seeing patients, is really focus on what you do well. And that is obviously teaching patients to do exercises appropriately, managing the quality of how they're performing those exercises, and then answering questions. And, if you're not feeling confident about answering questions about the surgery itself, although with these additional descriptions from Laurie tonight, that should be helpful, but certainly send patients to our website, excuse me, and then they can actually read through some more of that material, or if they have a number of questions, make sure that you encourage them to ask those questions of their surgeon. So the next thing that I wanted to talk about is just thinking about the patella. And here on the image on the left there, you see like a really beautiful alignment. The quadriceps tendon, the patella tendon, the patella is right in the middle there, just as Laurie was saying, exactly what you want to see, with the patella pointing directly to the ceiling or straight forward in somebody who's standing. And the challenge with a lot of these patients is that the patella is not in that position to start with. And then they have a dislocation, as is shown on the right there, where the patella, we're talking about recurrent lateral instability here, where the patella moves to the outside of the knee, so moves laterally. And that tears a number of the structures that are around the knee. And if we look at the next image, it actually shows us that, as Laurie was highlighting earlier, there's a number of ligaments. So the medial patellofemoral ligament can be differentiated from the capsule around the knee, as can the medial patellofemoral ligament, as well as the lateral patellofemoral and the lateral patellofemoral ligament. And sometimes with patients that tear their NPFL, they also tear their medial patellofemoral ligament. And one of the things that we may see in those patients is that they actually have a bit of patella alter or a high riding patella afterwards, because they've torn both the medial and the medial inferior restraints on the patella. So if we look at an MRI of these patients, there are often a number of tears, and you can see on the right side there of the image that there are multifocal tears of the NPFL noted there. So multiple strands of the patellofemoral ligament being torn. The other thing that you can see, and Laurie spoke about this earlier, is that the patella is no longer centered. It's actually sitting to the lateral side. And you can see as well that there is a note on that MRI about contusion of the lateral femoral condyle, because when that patella actually dislocates out, it's a huge amount of force for it to move laterally. And what tends to happen is that as the patella is going out, it's actually the medial rather than the lateral. So the medial side of the patella actually bonks onto the lateral femoral condyle. And so this is one of the reasons that these patients often have chondral injury. And as Laurie said, up to 95% of them will have some either bruising evident or an actual chondral lesion that we can see under the arthroscope. And it's one of the things for myself as a physio that's been really, I think, one of the most significant learnings I had in the first couple of years that I was in this role with the surgeons in Banff, is just seeing how many of these patients with joint injuries have chondral pathology. And it should be, as Laurie said earlier, the first thing you think about with a patient, particularly a patella patient that's having pain after surgery. It's most likely that they're having some aggravation or some increased pressure of that affected chondral area. And it's much less likely that they have, for example, fat pad impingement, or that they have a meniscal tear. Even though some of our clinical tests might be positive for those things, it's much more likely that it's actually the chondral cartilage that is affected in that situation. So if we look at the next slide, it's really showing you all of the resources that we have on our website. And so these are available to everybody, and I would encourage you to be familiar with them, but also redirect patients that have questions back to these resources. They're already there, and there's no need to reinvent the wheel. So there is an information sheet on the surgery with respect to the NPFL repair or reconstruction. And then there's the before and after surgery rehabilitation programs, as well as an information sheet on where people can find or purchase an electric muscle stimulator. And one of the things that we frequently say to patients, because for an EMS program to work, they really need to be using this 3 times a week. And so for the cost of an EMS unit, which is generally under $100, they can actually do a lot of their rehab at home. And as somebody who's treating those patients, it makes a huge difference to how much progress you can make every few weeks if they are actually following that home program. So we'd strongly recommend that you use those website resources. The next aspect that I want to chat about is envelope of function. So this is likely not new to many people, but it's one of the things we discuss a lot with patients is this envelope of function. So Scott Dye is an orthopedic surgeon who came up with this concept and really, started publishing and presenting on it way back in 2005, and really looking at the zone of structural failure, the envelope of function that patients have. And this is really specific to the theory of patellofemoral pain syndrome. So patients can take a certain amount of load at a certain frequency and kind of stay in that zone where they're actually able to function. And over time, we can often increase that load a little bit, maintaining the same frequency, or sometimes even increase the frequency, and patients can stay in that comfort zone. The challenge with these patients with patellar instability is that with that chondral lesion, they're really at risk of suffering from patellofemoral pain syndrome or developing anterior knee pain if you increase those patellofemoral pressures and don't give them adequate time to recover. And so one of the main things that we see with these patients that do have pain is that they may not actually have adequate core and hip strength. So it's a common thing we see when patients are coming back for their 6-month visit, and they already had a little bit of anterior knee pain at 3 months, and they've continued to progress through their rehab protocol without adequate rest to enable them to get back into this envelope of function. And it's a really important conversation to consistently be having with patients to keep them in that zone and to reinforce to them why, just like, whether you want to use the tree analogy that branches can't be strong without a strong trunk, it's the same with the core. You cannot function well in terms of your legs and optimizing your function if you don't have that good core to work from. So really avoiding that patellofemoral overload is the main thing that we talk about. And one of the things that we do see, because you may have, if you're thinking about the back of the kneecap, there might be an area of lesion in the middle of the kneecap or off to that medial side. And often we published a paper on this looking at the cartilage map on the back of the kneecap and actually showing that that central and medial inferior area were really common areas to get chondral lesions. And the challenge comes as patients are doing activities, for example, squatting, which is a really important closed chain exercise to develop quadriceps strength. You actually increase the amount of pressure that's on the facets of the patella in relation to the femur. And so it's really important that if patients do start to complain of symptoms, that we actually modify the range of motion to reduce the amount of pressure that's on that area. And this is another reason that we discuss the importance of seeing that OR report and actually reading and finding out where those chondral lesions might be. The other challenge that we do see with patients in terms of rehab is patients coming back at 3 months and they feel like they're doing really well. And when we actually assess their ability to do a squat, for example, even a double leg squat or a simple box squat, they're actually not able to perform that with a good technique. But they've already been progressed on in rehab to doing things like sumo squats. Excuse me. So it is really important to really keep patients' expectations in check in terms of just how long it takes to redevelop that muscle. And we know from the ACL studies now, more and more are coming out around both concentric and eccentric strength recovery after surgery, and showing that it actually takes up to 2 years for patients to redevelop the same level of strength they had before surgery. One of the other aspects that we reinforce as well is that when a patient sustains an injury, and this was part of the work that Dr. Hiemstra, that Laurie did in her PhD, when you sustain an injury to your knee, you actually have a dramatic reduction in strength in the muscles that surround the knee, but also in the opposite limb. And so when we're assessing patients after surgery, particularly in that first 6 months, we're not looking to see them be equal to their non-operative side. We're looking to see them maximize their strength in their non-operative side so that we actually have a reasonable comparison. And so what I'm meaning by saying that is, don't think that just because the operative leg is as strong as the non-operative leg, that the patient's already back to their previous strength. Chances are, based on the research, they're going to be at least 25% by 6 months post-op below what their pre-injury strength was. The other thing that I think is important to think about, excuse me, is making sure that range of motion's been assessed. So just if we go back to thinking about the gait cycle that a lot of patients with patellar instability adopt. So they develop this extension avoidance gait, and therefore they actually change the dynamics at their ankle as well in order to walk in that manner. And so what they end up doing is actually restricting their dorsiflexion range of motion. And so this is one of the other things we see in patients when we assess their squatting, is that they don't actually have adequate range of dorsiflexion. So same principles apply. Always assess joints above and below, always strengthen joints above and below, but it is something that we do see in that patellar instability patient population, is this a lack of range at the ankle because of these alterations in gait patterns that they adopt. So if we think about going back to Laurie's discussion around TTO, one of the things we know from biomechanics studies is that when we're doing open chain motion, the patella actually follows the path of the tibia. And this is due to the distal insertion of the patella tendon into the tibial tuberosity. And so the patella glides inferiorly with knee flexion, and then obviously superiorly with knee extension. And we should expect when the quads are contract, the patella migrates approximately 10 millimeters. And so that's the normal range of motion that you should be expecting to see. As the knee flexes, so you actually have the facets of the patella articulating more with the trochlea and with the medial and lateral condyles of the femur. And so the contact point actually moves proximally as the patella moves into flexion. And in theory, what should happen in this case is you have a bigger surface area that those patella facets have to be in contact with the femoral condyles. But because so many of these patients have chondral lesions, and some of them will even have that contusion that we saw on the MRI earlier over the lateral femoral condyle, you actually get these areas of focal pressure. And so it is important to remember that as we go into greater degrees of flexion of the knee, as you bend your knee more, it actually creates more pressure in the patellofemoral joint. So it's just an important thing to think about. And that's obviously in people with normally aligned patellofemoral joints. And so in those patients that have a misfit between their patella shape and size and their groove, the trochlea in the femur, this can be further accentuated. Next slide, please. And so one of the main focuses that we have in our rehab program, one of the things we've been really trying to strongly promote, particularly in the last 5 years, has been this use of electrical muscle stim, and really as a routine part of rehab. So I have to say, when I was training, neuromuscular electrical stimulation was kind of brought into a treatment protocol when a patient was struggling to recover. But what we know for the patella instability patients is that they'll do substantially better, and research has held this up actually for every type of knee surgery. The more that they use the EMS unit, the more they'll actually get that muscle adaptation. And as I said earlier, particularly important in those patients that have underdeveloped quads, even prior to sustaining a patella dislocation. When you have that patella dislocation, pretty much you've all probably seen patients, or patients who are on tonight themselves, seen just how much those muscles can waste. So huge advantage of that is patients can use it independently at home. And the two things that the muscle stim does is it reduces fast twitch fiber atrophy, which obviously is really important for the contractility of the muscle to generate power, and it also preserves slow twitch contractility. And this is particularly important because we do know that when we actually train patients afterwards in terms of functional recovery, eccentric muscle work is so important, and probably more so even than concentric work once the patient is able to fire the muscle well. And so when you are implementing the neuromuscular electrical stim, just in terms of the protocol, just making sure that they're using it within 2 weeks of surgery. So if patients have used it beforehand, they know exactly what it feels like. It's not frightening to them. It's actually a normal feeling. So that's another great reason to have them using it beforehand. And then they should be using it at greater or equal to 50 hertz. And at whatever is the maximal tolerable intensity for them. And obviously using these larger pads, if possible, with a 2 to 3 second ramp time, and making sure that that's biphasic so that we really do get the maximal benefit out of that. Thanks, Laurie. In terms of, that's good, yeah. So in terms of rehab considerations, what we really reinforce with these patients is just monitoring those muscle recruitment activity, their patterns and landing techniques. And this is all obviously very straightforward, but we really want to avoid those knock-kneed or risky valgus landings. And so really, encouraging patients to be landing with a technique that really shows that they're activating their core and their hip musculature as well. And then when they are doing glute strengthening exercises, which is so important, that they're not actually activating their hamstrings or their lumbar spine instead. So really making sure they're working in the range of motion that activates those muscles that we really want. And then, sorry, just to answer your question there, Kaya, really going with a cycle ratio of 1 to 2 or 1 to 3. So I'd probably start them 1 to 3 in that early phase post-op, and then adjust them to a 1 to 2. But if the patients have been using this beforehand, they're usually quite comfortable going for the 1 to 3 ratio, even within 2 weeks of surgery. And then talking about the phases of rehab. So I don't want to talk about these in detail, but just really to highlight them. So in this early postoperative phase, as I said, really trying to get the swelling down, keeping patients in this phase to 1 to 3 weeks, making sure patients are resting and elevating their leg a lot so that we don't end up with stiffness in that patellofemoral joint. And then really the big focus on activating the quads and specifically trying to get the VMO activated. And obviously research has borne out that, yes, you can get some bias towards activating the VMO fibers, but really you can't isolate aspects of the quadricep musculature. You have to activate them all. So another reason that we really emphasize using that muscle stim, particularly over the medial portion of the quadriceps muscle there. And then some patients will have more or less pain, which will enable them to progress sooner or later. And then also ensuring before patients move on that they have full knee extension and that they have knee flexion of around 60 degrees.
Eric, can I just, sorry, can I just jump in here about knee flexion? Just because it seemed like a good time. So I know when we first started doing patellar stabilizations, patients, or after an initial dislocation, patients are locked in extension. And there was a lot of fear about initiating range of motion, but I just wanted to, especially to protect the graft postoperatively, I just wanted to emphasize that the graft loosens in flexion. So a lot of these patients, weirdly, complain of pain, and it feels so tight medially, and it feels like it's going to rupture my graft if I bend my knee. But the fact is the graft actually gets looser in flexion. So that's a really good thing to understand, because their knee is tight because there's swelling and it feels stable, but you will not injure the graft or stretch the graft by encouraging the patient to flex their knee.
Thanks, Laurie. So yeah, so for the second phase of rehab, we're now into the muscle strengthening phase, and this can take a considerable amount of time. Laura, can you just bump the slide on to the second phase, please? So this is really where we're wanting to see that quads activation and really starting to emphasize that core stability. So obviously we're going to still manage pain and swelling, progress that range, and we're wanting to see it to 90 degrees or greater by the end of that 6th postoperative week, and really wanting to see good quadriceps muscle contraction. So obviously this is vital to the patient's outcome. And having the stationary bike in daily rehab just to really get patients more and more comfortable with moving their knee. And this is because a number of these patients who've had patellar dislocation get quite anxious. And as Laurie said, they can feel like suddenly that medial side of the knee feels really tight. And so we want to reduce the amount of resistance and the amount of fear and anxiety they have around moving the knee. And the stationary bike is a great way to do that. And so you can see here what the requirements are for progression to phase 3. And we really don't want patients moving on to phase 3 until they're doing these things really competently. And one of the things that we have as a conversation with a lot of these patients when they're in that 8 to 12 weeks post-op and they haven't yet progressed on is just to really encourage them to do the very best they can in this phase, because it really does set the groundwork for their successful outcomes. And then when they do move on to that third phase, so Laura, if we can bump to the phase 3, this is when we're really getting into that progressive strengthening, but also a lot more functional activities and doing balance and potentially agility activities as well. But also for those patients who've had a lot of instability, or they might have had, for example, 6, 10, 18 patella instability episodes or frank dislocations, it's obviously going to take them longer because their muscles have been in a state of wasted state or a state of hypertrophy for a long time. So we want to really get those hyperplastic quads reactivated or address that muscle wasting as best we can. And so now we're wanting to see, much better quads contraction. Sorry, Laura, can we bump it to the third one? And then starting to get patients focusing on a normal gait. And so this can also be a real challenge because they've been walking with that extension avoidance gait for a long time. And again, really important to address any lack in ankle dorsiflexion range, and then getting into proprioception and balance. We do still really encourage patients in all of our rehab protocols to be doing that. Canada Health guidelines recommended 20 to 30 minutes a day of aerobic activity. One, obviously, because it's very healthy for people, but two, because it really helps people's mental health as they're recovering from their surgery as well. And then obviously increasing their quads, hamstrings, glute, and core strength, and really helping patients to build on that and progress, particularly the core and gluteal strength, which is so important for their long-term outcomes. And so for progression to phase 4, this is sport readiness. It's important to note that some patients might not ever get here. A number of patients who've had long-standing recurrent instability and who have a number of intersecting factors in terms of Perhaps they have trochlear dysplasia. They have, really hypoplastic quads. They may have also needed a tibial tubercle osteotomy, a distalization because they had patella alta. They may have, for example, generalized ligamentous laxity, and those may not be consistent with them being able to get back to a sport per se, a pivoting or a running sport, but they may be able to get back to a lot of their previous activities. And so this phase, the earliest it should start is 3 months after surgery, but it usually starts around 18 weeks. And so some of the patients that have a traumatic dislocation, like a frank traumatic dislocation, who don't have a lot of underlying factors, will actually be able to progress quite a bit more rapidly to this phase. But as a general rule, we see patients starting this, 4 or 4.5 months after surgery. And it can, as I said, progress and last up to 2 years afterwards. But we're really wanting patients in this phase to be improving their strength, their agility, making sure that if they do go on to plyometric exercises, that they don't start them until they're, at least 12 weeks post-op, just to ensure that they've got really good bony healing for those tunnels. And then for those patients who are returning to sport, just like we would with our patients who've had an ACL reconstruction, making sure that they progressively go back to drills and activities, doing sport-specific training programs before they progress back to sport, and making sure as well that they do some objective testing before they progress back to sport, making sure that they are actually able to do that and making sure that the patient is ready. And obviously there are a number of different testing batteries that can be used for this. There is a functional testing video on our website that you can just put in functional testing in the search box and it will come up and show you the testing that we do use for patients. And so making sure that that's addressed as well. And as I said earlier, also making sure that eccentric strengthening is adequately addressed, particularly for athletes wanting to return to sport, so we minimize their risk of injury.
All right, so wanted to talk a little bit about bracing. There's been a couple of questions and I'll try to address them in the chat. So as you know, the patellofemoral joint is really a very unstable joint. So it's not like the hip that has a lot of bone containment. It's really a little sesamoid bone floating on a groove of varying deepness. So we want to use bracing, and bracing is a tool that can help us. But the reality is bracing is never going to cure patellas because it's just physically impossible to contain that patella and the forces that your quadriceps can generate with an external brace. But they can be very useful. So let's talk first about post-surgical bracing, and then I will address, Meryl had a question about a initial dislocation, and I'll address that too. So early post-operatively, when I started doing NPFL reconstructions, I kind of went with the literature that, everyone, and especially Americans, are much more conservative in their range of motion. And everyone would lock people's leg for like 2 to 6 weeks, lock them in extension before they start moving. And what we found is, just like Sarah's been talking to you about for the last half hour about getting those muscles activated, is these people would have just profound quadriceps deactivation, and it would be forever to get their muscles firing again. And there really is no biomechanical reason that we need to lock people straight. The fact is if your knee is straight, you cannot dislocate your patella because you're not bending it and you're not firing your muscles. So you're really defunctioning the muscle to prevent your patella from dislocating. When we put in that NPFL reconstruction we put in is actually quite strong. It's much stronger than the NPFL the Lord gives you. And so it can overcome some of that. So again, if in a controlled situation, we use bracing then to protect our patient, to provide a feeling of confidence and stability to their leg, maybe not even their patella, but to their leg, and allow them to be safe, especially in our Canadian winters. So we now allow full range of motion post-operatively. And as we mentioned, as you flex your knee, that patella actually enters the groove. When your knee is flexed, nobody dislocates their patella in 90 degrees of flexion. Like, you bend your knee to 90 degrees right now and try to translate your patella. It doesn't move because it's fully engaged in that groove. And even people who have a shallow groove, by the time they get to 90 degrees of flexion, There's enough groove there that it will contain your patella. So there's nothing wrong with flexing your knee. We know your graft is actually not even functioning in flexion. Remember, I told you it loosens in flexion. So we allow full range of motion immediately post-op. There are some patients who are very tentative. So if you've treated patients with patellar instability, you know there are some psychological factors. I've never dislocated my patella, but I think it's horrible because they are terrified to allow that patella to dislocate again. So putting a hinged brace on them gives them some feeling of confidence. It allows range of motion. If that's too much for them, you have the option of locking the brace for a couple days, but that's to treat the patient and to treat their needs. It's not necessarily to protect their surgery. So hinged range of motion brace until they have good enough quads function that their quads can protect their knee. So really what we're trying to do is protect that surgery until they get enough quads to protect their surgery themselves. So my general rule is they're in a hinged range of motion brace, they're full weight bearing. That can be adjusted according to the needs of the patient, but that would be the norm. And then I transition them into a patellar stabilizing brace. So again, this may provide them a little less support, but it's much more palatable to wear. They can wear it under their clothes. It's not so big and bulky. They're over the main scary part of the first couple of weeks post-op, but it still gives them a little bit of support and proprioception to protect our surgical procedure. So my general rule is, and honestly, Laurie made up these rules, so these are not carved in stone, but the principles would be is if you have enough quads function to do a straight leg raise, so your quads are strong enough basically to lift your tibia and your foot, you should have enough quads function to protect that knee for walking around and maybe small slips. So then you can transition into the patellar stabilizing brace. And then what I tell patients is that as their quads get stronger and stronger, they need the brace less and less. So first they would wear it maybe all day while they're up and about, but they don't need to wear it in bed. I mean, in bed, they don't need any brace unless they need it to make themselves feel better. And then they might need it for playing sports, but not for everyday life. And then they might need it only for pivoting sports, but not all activities. And so you decrease the brace as their quads function and core function improves. And really, it's just a matter of using a tool to help the patient. So post-operatively, if a patient is not of normal size, so if they're very large or very small and the brace does not fit, the hinged range of motion brace, I don't mind if they don't use it. They just have to be more careful because they don't have that extra protection should they slip and fall. If the patient is lying in bed, they are unlikely to slip and fall, so they don't have to wear the brace while they're in bed. If they have to get up to the bathroom in the middle of the night, if they can be careful, that's a time where they might be at risk. They either be extra careful, or if they can't be, they should put the brace on to protect them. So it really is a tool. There's no hard and fast rules. And if the brace is not helping people and they hate it, then they might be better off and might actually pay more attention without the brace. So again, this is how I use it post-operatively. And again, I think just remembering it's a tool to help the patient. It's not the surgery. The surgery is what's fixing them. The brace is helping them recover. With regards to first-time dislocator, there's lots of controversy about this around the globe, but if you talk to the patellofemoral experts, so if you go back to your biomechanics, it makes absolutely zero sense to brace someone in extension after a patellar dislocation. You saw that MRI that Sarah showed. Someone has an acute patellar dislocation. That patella is sitting off laterally because all those medial structures are torn. The patella is sitting laterally. If the patella is sitting laterally, that means that NPFL is in a big, long, stretched out position. So if you lock a patient in extension, that's where the NPFL is going to heal, in a big, long, stretched out position. You're also going to totally deactivate their quadriceps, because if you are locked in extension, you do not need to fire your quadriceps to walk. So yes, it's true that locking them extension means they won't dislocate again immediately, but it actually is counterproductive to healing of that ligament. What we want to do is put the patella back in the groove so that the NPFL is in a shortened position, and hopefully it heals in a good position with the patella in the groove, and maybe that patient will not have a recurrence. We know that in patients with relatively normal anatomy, maybe 50%, 30 to 50% will go on to recurrent dislocations. But all of those patients and that natural history has been determined by splinting them in extension. So if I had a choice, if I dislocated my patella today, I hope I don't, I would actually splint my leg in 30 degrees of flexion. I would allow full flexion, 30 to full, because when I'm flexing my knee, my patella is located in my groove. That means my NPFL is in its shortened anatomic position and it hopefully heals there. I would leave it there for 2 to 3 weeks, and then I'd allow motion to hopefully keep my quads firing a bit. And then I would slowly stretch them out into extension and get them activating as soon as possible. I hope that answers your question, Meryl. Does that answer it? The problem with that is no patient wants to be splinted for 3 weeks in 30 to 90 degrees or 30 to full flexion. It's not very comfortable, but if it stopped you from having recurrence and dislocating again and having surgery down the road, it might be worth it. So that would be, sorry, yeah, go ahead, Sarah.
And just to add to that, and so as I was saying earlier, with open chain, the patella follows the path of the tibia because that's where the patella tendon's tethered. Likewise, this is why you want closed chain exercises in those patients who have had an acute dislocation or are post-op, because we want to activate the quadriceps muscles while the patella is relatively tethered. And by activating the quads, you tether the patella because the quadriceps tendon is now placing a lot of stress on the patella through its activity.
Sorry, there was just a question from Moira. Would I change that protocol for recurrent? So I would argue if they've dislocated 10 times already, the chance of, even if I put that patella in that reduced position, that tissue is so beat up and so torn that it probably wouldn't work. So I would change it, honestly. If they're recurrent and symptomatic, I would operate on them. So I think that works in a first or maybe a second time dislocation. I think you also want to take into account, I mean, if a person has high grade dysplasia and patella alta and is a young age at their first dislocation, the chance of that protocol working, I mean, they're kind of a doomed knee. So I think you want, the chance of that being successful depends on a lot of other factors that we've already discussed also. But I think once they start dislocating multiple times, it's a bit like a shoulder dislocation. That tissue is pretty beat up and not very robust. And I think the chance of that working just goes down considerably. All right. Oh, good Lord. We're almost on final thoughts. There we go. Rehab. So the last thing we wanted to talk about was just about managing patients' expectations. So if you treat ACL tears, like those tend to be quite athletic people, and they really have very high expectations of getting back to their sport. Patella instability patients are a little bit, they're of a wider genre. So you have some that are exactly like ACLs. They've actually lived a lot of their life being very athletic, and something happened, they dislocated their patella and they want to get back to they're very much like an ACL reconstruction. The patients that have been dislocating their patella since they were a very young age actually tend to have tempered their activity levels and tempered their expectations so much because they've been so disabled for so long. So it's really important to understand that not all patellas are created equal, or not all patients with patellar instability are created equal. So there are some that really, they just want to get back to life. My favorite story is I had one of my early patients. She's like, Laurie, she goes, I've got young kids, my patella keeps dislocating. All I want to be able to do is walk my 5-year-old to the bus stop and be able to get the mail out of the mailbox and go home. And if I could do that, I'd be so happy. So we fix her patella and she goes away and she does all her rehab. And what did we see her, Sarah? 2 years, or we brought her back at 5 years or something for one of our studies.
Yeah,
and
she came back 4 years post-op.
Yeah, her 2-year quality of life score was like 80 something. She was so happy, everything was great. And then we saw her at 4 or 5 years and her quality of life score was like 50. I'm like, what's going on? What happened? Like, why aren't you doing? She's like, well, my knee, yeah, it's better than it was, but I can only play soccer like 3 times a week. And I really want to play 5 times a week. And it's just like, so her expectations changed so dramatically from walking to the bus stop to wanting to play soccer more than 3 times a week. And requisitely, her quality of life score went down, which is super interesting because her activity level was just so vastly improved. So it's just a funny story, but really managing patients' expectations. Most patients, more than half of patients do have considerable anatomic abnormalities that predispose them to dislocating their patella. So the number of patients that actually have normal anatomy and have pure trauma that dislocate is actually really quite low. So some of these patients, the realization, like, we can fix their patella, we're quite good at stabilizing it. Sometimes pain and those chondral lesions can inhibit. Sometimes, you know, we can fix it, but we might not be able to fix it stable enough that they can be an Olympic athlete, because those predisposing anatomic features are still going to be there. So managing these patients' expectations is a little bit more work than managing the ACL reconstruction, in my opinion. And that's just because there's just a wider breadth of patient that comes to you. And like we said, they all have different anatomic predispositions. So looking at their level of function and being realistic with them is important. I think some of these patients that are really disabled preoperatively are actually greatly surprised by how good they get. But there's also the patients that maybe the patellar instability came later on, and they will be frustrated that they can't get back to the level that they were at. And so that's just a good thing to keep in mind as you rehab these patients. So some final thoughts. Sarah's alluded to this. We collect outcome measures, and Banff Sport Medicine has actually been very active in creating outcome measures for patellar instability that are now used around the world and translated into multiple languages. We've been collecting mostly quality of life scores, as you've all seen. We also do functional testing, so all the HOP tests. But other things we've been exploring are some of the other aspects. So again, some of the psychological aspects, and we mean that, like the kinesiophobia. I mentioned that, you know, if you dislocate your patella, these patients are like, they're terrified to dislocate it again. And there's a huge psychological aspect to that kinesiophobia and that fear of re-injury that's very real and can impact their rehabilitation and their function afterwards. So this is a very important part of treating these patients, and we're doing some research into some of these aspects. The pain catastrophizing scale, this is well, I can talk forever, but I won't. But this is a really interesting thing, because a lot of patella patients, like, you know, people go, oh my goodness, that patient just goes crazy about the pain. But there's lots of incidences where you fix their knee and all that catastrophizing type behavior actually goes away. So there's chicken and there's egg, and a lot of these scales, like the kinesiophobia and catastrophizing, we really don't have a good understanding of, but they are really impactful to the rehabilitation and treatment of these patients, and we need to understand more about them. So in conclusion, patellar instability is challenging to treat, and that's why it's so much fun. And the fun part is every patient is unique, and they all have different needs and wants, and they all have different anatomy and different function. So it really is complex, but it's very, very gratifying to help these patients. But understanding the biomechanics is the key. So really understanding how to approach these patients. It's really a rational approach in thinking about why we're doing things, what we're trying to accomplish, what did the surgery do, and not being too afraid of getting these people moving and getting those muscles activating. We do want to be careful about pain in these patients, and it's probably the biggest struggle in treating these patients postoperatively is that postoperative pain. And a lot of it is functional pain just due to poor movement strategies and poor core. Some of it's chondral lesions, but trying to figure that out can be very, very challenging. And then return to sport really is dependent on muscle function. So doing those phase 4 exercises and doing that readiness for sport testing, like we do for our ACL reconstructions, is really how we decide when patients can go back to sport. And I think that's all. And I haven't been paying attention to the chat, Sarah. I don't know if you have. Here we go.
Yeah, we do have a few questions there to answer. So Lisa, I'll tackle your question about chondral lesions. So pain is a huge factor with these patients. And so generally what my recommendation would be is that if a patient does an activity and still has pain and or swelling more than 24 hours later, then we need to reduce how much we're doing. But if we go back to thinking about closed kinetic chain exercises, so the patella is relatively tethered there in the quad tendon. So when you flex, it's actually the lateral, the femoral condyles that actually translate behind the patella when you're going into flexion. And so this is why it's so important to have really good quality movement. So if you think about the patient who internally rotates their femur, what they're doing is actually closing down between the lateral femoral condyle, where we know patients can sustain an injury with a patella dislocation, and the lateral facet of the patella. So if that's giving someone pain, then it may be because of chondral pathology. And so we really need to think about the actual mechanics of what's happening in 3 dimensions with that patella. And likewise, the patient who, tends to abduct when they squat, for example, that may actually also give them pain because of increased compressive force on the medial side of the patella facet. So really thinking about balancing that. And so, yes, it's not unreasonable for these patients to have some discomfort, but they shouldn't have pain, and they certainly shouldn't have pain that progresses. And so, I think, keeping them in that envelope of function is super important, and progressing them when they're already having pain symptoms is just a recipe for disaster, because these patients then go on to have that recurrent anterior knee pain. And once they have it, it's really, really hard for them to recover from it. So if they start having symptoms that last for more than 24 hours, I would say back off and get them focusing more on core and hip until you can progress them again. Laura, did you have anything to add?
Sorry, my slideshow is going crazy. No, I think that's good. I think that the key is the no pain, no gain thing. You should never have been said by anybody. You have to keep them, discomfort might be okay, but pain and pain that increases with the activity is bad, 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 bad. Does that answer that? So there was a question about K-tape. I absolutely love taping. So of course, Jenny McConnell has done a lot of work on taping the patellofemoral joint. I don't know, we probably use a modified McConnell or something at this point, Sarah, but to me, taping and bracing is, again, we're looking at principles, right? We're trying to accomplish the same thing. The brace will have a little pad that tries to hold the patella medially or try to stop it from going out laterally, and your K-tape will do the same thing. For my patients, to me, the taping works better than a brace. But there's good and bad to everything. So the tape lasts for a shorter period of time, maybe. So like my athletes who want to still compete, I'll say tape and brace for games, but you may want to brace for practice, because if you tape every day, your skin will break down. So I think using both of those, we're trying to accomplish the same thing. I think for sure, well, patellofemoral pain is a little bit different than instability, I guess, and we use taping for patellofemoral pain. I can say that the taping is the patients that come with a subtle instability, like the micro instability, or had a subluxation and not a great history, I've often asked the physios to tape them and see if the patient, as a bit of a test, see if the patient actually feels more stable with the tape, because I think tape does a better job, at least in those first few hours, than a brace. It's just hard to be taped at all times. So I hope that answers that.
And I would just add as well that when patients have that first-time dislocation, there's a question there, Laurie, about whether or not we'd want to brace all first-time dislocations. And as Laurie's already said, like some of those patients will actually do quite well with tape. But if patients had a frank dislocation, if you think back to that MRI, you will have actually had disruption of the medial structures. And so the sooner we can get that into a shortened position, just like we do with the MCL, because it's also extra articular, the better chance we have of improving the strength of it while it's healing.
Yeah, and I would argue, I feel that so to me, all first-time dislocations should have an MRI within a week and should be braced in 30 to full, ideally for 3 weeks. To me, that would give them the best chance of having a good result. So the MRI, because we miss in Canada so many osteochondral fractures from an acute dislocation, we miss them. And that should be standard of care. It's just not, because we don't have access to MRI and people aren't quite ready to do that here yet. That just leads to that referral question. And the answer to that is yes, but no. The reason being, we take all our referrals through sport medicine physicians. And these patellas actually need some workup. So I actually will not see a patellar instability unless they've had a CT or an MRI. So they need some extra workup, not just a referral to a surgeon, and they need to be followed, especially first-time dislocations. So we prefer them to go for a fairly quick referral to a sport med physician who can order appropriate advanced imaging, and then see if they need referral onto us. So I hope that answers that. And here's Jacob. So so Jacob asked about injection therapies like Prolo for NPFL stability, and my answer to that would be no. I have not seen any evidence, and okay, I'm biased. I cannot conceive of how Prolo could stabilize an NPFL. So I would rather see them spend their money on an EMS and a physio and a trainer to improve their core stability and their strength than to spend money. Having said that, some injection therapies we have used quite successfully, which would be intra-articular. So intra-articular hyaluronic acid plus or minus steroid can be helpful in certain patients where we need to control, who have a chondral lesion and we maybe need to control some swelling and pain. We have used intra-articular injections with some success, but not extra-articular. And so the question was MRI or CT. The answer is MRI. So I get CTs because I can't get MRIs in a timely manner. So, but my preference would be an MRI. And honestly, my preference would be a bilateral MRI because at least 50% of these patients will have bilateral symptoms eventually. The benefit of the CT is you can get it quicker, and you actually get images of both knees in your CT scan, but the MRI would be the modality of choice for that.
The challenge with ultrasound instead of an MRI is it really is not able to differentiate those injuries. So while it might, for example, show an acute hemarthrosis is evident after an acute dislocation, it really is impossible to differentiate anything else. And so I think that, you know, ultrasound can be guilty of overcalling its ability, or the practitioner might be guilty of overcalling what they can see with an ultrasound, and in the setting of an acute dislocation, it really is very difficult to differentiate unless you have a high quality MRI.
Yeah, the purpose of the MRI, just so we're clear, is number one, in an acute case would be to see an osteochondral fracture, which is not always evident on X-ray. But the reason I need an MRI on everyone is I need to determine what their anatomy is. So I cannot grade or see trochlear dysplasia. I can on a lateral X-ray, but not fully unless I have axial imaging. So the axial imaging lets me calculate their TTTG, which is a measurement basically that tells us what their Q angle is. So if their tubercle is lateralized, it tells me, it can give me some idea of their through knee rotation. It can give me some idea of rotation. So it's a very specific anatomy I'm looking at on the axial images of the MRI. So an ultrasound, yes, it's an imaging, but all that's going to tell me, it's not going to tell me anything I don't already know. You know, so the things I need to know, it can't tell me. So it actually is, it's useless to me for that indication. Any other burning questions? Okay. Thank you all for spending the evening with us. I wish I could have seen all your faces though. Maybe we can do it in person.
Yeah, thank you, Laurie. Thank you, Sarah. That was fantastic. And thank you all for your great questions. We hope to do this again soon.
Have a good week, everyone.
Thanks so much, everyone. Take care. Stay healthy.